Okay, go ahead and get started with our Neurocritical Care Pharmacy Journal Club today. And so I have the pleasure of introducing, we have two speakers today. We have Madeline Scarborough, who is from UT Southwestern Medical Center, and we also have Danielle Murray, who is from Ohio Health Riverside Hospital, and they are both PGY2 critical care pharmacy residents who will be presenting today. So I'm going to stop sharing here. Madeline, if you want to then share your screen.
Sounds great. Let me make sure we do this correctly this time. Are you seeing my main slides, Colleen? In presenter mode?
Yes.
Okay, thank you.
Yes, we can see your first slide. So
awesome,
go ahead
thank you.
and get started when you're ready.
All righty, let me put this up. All right, hi everyone. My name is Madeline Scarborough, and I am the current PGY2 critical care pharmacy resident at UT Southwestern Medical Center here in Dallas, Texas. And today I'm going to be discussing the article Tenecteplase for Stroke at 4.5 to 24 hours with perfusion imaging selection. This is also known as the Timeless Trial. And if you hadn't had a chance to read the article prior to today's journal club, it is on New England Journal of Medicine, published back in February of this year. And it really aimed to provide further insight into the possibility of extending the window for thrombolytic administration for acute ischemic stroke. So as the treatment of acute ischemic stroke has continued to advance, we are starting to see more trials come out similar to the one we'll be discussing today. Currently, our standard of care for eligible patients presenting within that 4.5-hour window of symptom onset, the standard of care at this time is to administer IV thrombolytics plus or minus consider endovascular therapy in select patients. And this is mainly done with mechanical thrombectomy. And then when we're considering whether or not to utilize alteplase versus tenecteplase, we do have evidence to suggest that tenecteplase is at least as effective as alteplase and may provide some practical advantages that we'll discuss more on the next slide. And when considering endovascular therapy for patients, it has been shown to be beneficial for up to 24 hours in our Diffuse 3 and our Dawn trial, especially in patients with large vessel occlusions, as we see more favorable functional outcomes, especially when compared to medical therapy alone. And so both agents, alteplase and tenecteplase, are recommended by guidelines. We do have a lot more data coming out looking at tenecteplase for acute ischemic stroke. Okay. But ultimately, they both result in the conversion of plasminogen to plasmin as shown on the screen here, and that will ultimately degrade our fibrin clot. The real difference between the two relates back to the chemical structure of tenecteplase. It is almost identical to that of alteplase, but it has 3 different point mutations on the structure. And this allows tenecteplase to be more fibrin specific. So here on the screen, it will likely be acting more at the site of an active clot rather than systemically. So hopefully we'll be able to reduce overall systemic bleeding. Furthermore, the chemical structure of tenecteplase allows it to be have less binding affinity to an enzyme known as plasminogen activator inhibitor 1. And essentially this enzyme breaks down our IV thrombolytics. And so that's why tenecteplase also has a little bit of a longer half-life compared to alteplase when we're talking about 5 minutes versus 90 minutes and longer. And with that, tenecteplase is able to be administered as an IV bolus over 5 seconds, where alteplase, we have to give a bolus the 10% of the dose and then followed by a continuous IV infusion. So it does provide some practical benefits for ease of reconstitution and administration as well. Our current guidelines do recommend alteplase administration for up to 3 to 4.5 hours after stroke onset. And this standard of care 4.5-hour timeframe really goes back to some of our key landmark trials where the NINS trial showed benefit of alteplase for up to 3 hours after stroke onset, and the ECAS-3 trial supported the efficacy of alteplase for up to 4.5 hours. There is data supporting IV thrombolytic administration beyond 4.5 hours with alteplase in select patients based on MRI imaging. And this was shown in the Wake Up trial looking at efficacy for wake up stroke or unknown time of onset. And then we already touched on tenecteplase may be a reasonable alternative. But we've since 2019, when these guidelines were published, we've had a large amount of data come out looking at tenecteplase compared to alteplase and just tenecteplase's use in general. So the European Stroke Organization did put out some expedited recommendations related to tenecteplase use back in 2023, so just last year. They also recommend tenecteplase can be used as a safe and effective alternative to alteplase. And their expert consensus actually favors tenecteplase over alteplase within that window of 4.5 hours. And just to wrap up our guideline recommendations, specifically focusing on thrombectomy, we do know that patients that present within 6 to 24 hours with large vessel occlusion should be considered for mechanical thrombectomy. And the criteria for this goes back to our DAWN and DIFFUSE 3 landmark trials. These were the two first landmark trials really showing the benefit of mechanical thrombectomy. So before we dive into some of the studies that have led up to today's trial, I wanted to just quickly review some key functional and imaging outcomes for acute ischemic stroke. This will be important as we evaluate our study today and compare it to previous landmark trials. So the modified Rankin scale score assesses disability after stroke. This is often a primary outcome in a lot of literature to assess how a patient recovers following the acute ischemic stroke. And typically an MRS score of 0 to 2 is often associated with a favorable outcome, as this means the patient likely has little to no disability following recovery of the stroke. The National Institutes of Health Stroke Scale score is important for including patients based on stroke severity. So this is often included as maybe an inclusion criteria or looking at in the baseline characteristics to see how it compares to other studies as well. And when we talk about large vessel occlusions, I wanted to highlight a few that we'll be focusing on today, since the patients in the trial we're talking about do have to have evidence of an LVO. We're going to be focusing on the internal carotid arteries. These are the biggest arteries that go into the brain. They help form the circle of Willis and supply blood to the anterior, middle, and posterior cerebral arteries. We'll also be looking at the middle cerebral artery as well. These are a pair of arteries that branch out and supply blood to the temporal lobes and parts of the frontal and parietal lobes. So both vessels are extremely important for our overall cerebral perfusion. So as you might imagine, when they get occluded, we can get pretty severe damage. Typically, when we have damage right away to regions with very low cerebral blood flow, those areas can become rapidly, irreversibly damaged. So when we're looking at imaging, whenever we have this irreversible damage, that is what we refer to as the core. The area surrounding the core does have a little bit less severely impaired cerebral blood flow. This is known as the penumbra, and we'll oftentimes utilize imaging to assess the penumbra volume. This gives us an idea of how much tissue could potentially be salvaged, and it's often an inclusion criteria in some of these studies involving imaging and mechanical thrombectomy. And then, of course, the area surrounding the penumbra is often healthy tissue. So our goal is to really salvage the penumbra and prevent this area from increasing in size. And after patients undergo mechanical thrombectomy, there are some important scoring tools we can utilize to assess how well we did in terms of perfusion. So the Tiki score will be mentioned in today's trial. This assesses the degree of reperfusion directly after the mechanical thrombectomy. So here you'll see a score of 2B or 3 is often a favorable outcome in our trials. This indicates that after the clot was removed, there is at least 50%, if not full perfusion, filling into all of the distal branches. We can also utilize what's known as the arterial occlusion lesion scale, and this looks at the degree of recanalization specifically in the occluded vessel. And a favorable outcome is often associated with a score of 3, which means the patient has complete recanalization and restoration of the target artery with any distal flow. So keeping some of these outcomes in mind, we talked about functional outcomes in imaging and perfusion. I did want to highlight some trials looking at alteplase beyond 4.5 hours. So we've had a couple landmark trials looking at alteplase versus placebo use in a more expanded time frame from 4.5 hours all the way up to 9 hours. The first 2 trials really didn't find any benefit in extending the window with alteplase as compared to placebo in terms of patient functional outcomes utilizing the MRS score of 0 to 1. These trials also didn't find any differences in terms of symptomatic intracerebral hemorrhage or other bleeding events or safety outcomes. But the Extend trial published in 2019 is really kind of what made this a controversial topic. These patients that received alteplase between 4.5 hours to 9 hours actually did show signs of a potential functional benefit by having an MRS score of 0 to 1 at day 90. And this was more likely to occur in those that did receive alteplase. But there's a lot of hesitation with extending the window because although the study found more favorable functional outcomes, there was an increased risk of symptomatic intracerebral hemorrhage with extending the window. And then later on in 2019 by Campbell et al., there was a systematic review and meta-analysis conducted, which included these 3 trials and overall showed, again, possible functional benefit, but definitely increased risk of bleeding. So that's why currently it's not a recommended strategy for all patients beyond the 4.5 hour mark. On the other hand, we have even more limited data looking at tenecteplase beyond 4.5 hours. The trial by Kate et al. In 2018 was more of a proof of concept study. So these patients received either tenecteplase or placebo from 4.5 hours all the way up to 24 hours after stroke symptom onset. And the primary outcome here was incidence of symptomatic intracerebral hemorrhage, which they found no difference. But they looked more at imaging and reperfusion as secondary outcomes, and they were able to find that penumbral salvage volumes were higher with the use of tenecteplase. So this trial, although we saw favorable imaging outcomes, they didn't assess any clinical outcomes. So we're kind of left with a question mark on what to do beyond this 4.5 hour window. The TWIST trial published just last year did aim to address this question, but more so focused on awake strokes rather than a specific extended time period. And whenever we looked at tenecteplase versus placebo, there was no difference in functional outcomes based on the MRS score at 90 days, and rates of symptomatic ICH were not different as well. So all that to say, treatment with thrombolytics is a standard of care for patients arriving within that 0 to 4.5 hour mark. We're still left unsure what the best strategy is in terms of patients that prevent outside of that window. Of course, those with large vessel occlusion should be evaluated for mechanical thrombectomy, but in terms of thrombolytic eligibility, that is what this study, the Timeless trial, set out to look more into. So the objective of the Timeless trial was to determine if IV tenecteplase given within 4.5 hours to 24 hours after stroke onset would provide a benefit in patients with large vessel occlusions and evidence of salvageable ischemic brain tissue. And we'll talk about what those requirements were on the next couple of slides. This was a multi-center double-blind randomized placebo-controlled trial, and it included patients that presented within this extended window with evidence of salvageable brain tissue and large vessel occlusions. Sites from all over the United States and Canada were included. A majority of these were large academic medical centers with thrombectomy capabilities. That will be important to note later on. And then patients were able to be enrolled and receive either tenecteplase or matching placebo from March 2019 through December of 2022. The primary outcome of this study, similar to a lot of our previous landmark trials, was looking at functional outcomes, so the MRS score at day 90. Key secondary outcomes was looking at more of imaging and reperfusion. So the investigators took a look at recanalization with the arterial occlusion lesion score following thrombectomy. They also evaluated whether or not the patient had 90% penumbra volume reduction at 24 hours. And then following mechanical thrombectomy, they also evaluated the Tiki score to assess reperfusion. Other key safety outcomes was death at day 30 and day 90, and then safety outcomes also included symptomatic intracerebral hemorrhage. I also wanted to add the MRS score was collected either in the clinic at 30 and 90-day follow-up, or the patients were allowed to have telephone contact with the investigators to provide the MRS score. Other key inclusion criteria, patients had to have a baseline MRS score of 0 to 2 prior to the stroke that brought them in for the trial. This was just to prevent any patient with already baseline severe disability from impacting the results of the study. Patients also had to present with at least a moderate stroke severity score, and this was based on having an NIHSS score of at least 5. And in terms of large vessel occlusion, patients had to have blockage of either the ICA or the M1 or M2 segment of the middle cerebral artery, which are the two vessels that I pointed out a few slides ago. And criteria for evidence of salvageable brain tissue included having an initial ischemic core volume of less than 70 milliliters, having an ischemic tissue to infarct volume ratio of greater than or equal to 1.8, and having signs of penumbra volume of at least 15 milliliters. And if you'll refer back to the diffuse 3 and the Dawn trial, these are very similar criteria to those patients that were included in the study for mechanical thrombectomy. Exclusion criteria aligns very similarly to the contraindications already in place for both alteplase and tenecteplase. So patients with any evidence of active internal bleeding, any type of hereditary coagulopathies, treatment with thrombolytic within the last 3 months, and pregnant patients were excluded. This study also excluded patients with severe uncontrolled hypertension, so those with a blood pressure of greater than 180/110. They didn't make note of whether or not patients could receive antihypertensives to decrease the blood pressure and then be enrolled. There was no mention of that in the supplemental appendices as well. So after patients were randomized on day 1 here, they were either assigned to receive tenecteplase or placebo, tenecteplase at 0.25 milligrams per kilo with a max dose of 25 milligrams. And then based on the vessel that was occluded, providers then decided if the patient were to undergo mechanical thrombectomy shown here. So those with an ICA occlusion or an occlusion of the M1 segment of the MCA, which is the key 2/3 of that vessel, were eligible to undergo mechanical thrombectomy. And then those who had an M2 occlusion of the MCA, the physician was able to decide whether or not the patient wanted to undergo thrombectomy. So it was up to the physician's clinical judgment. Further imaging was then done 24 hours post-treatment of the thrombolytic and/or mechanical thrombectomy. And then safety outcomes, specifically the symptomatic intracerebral hemorrhage and any type of parenchymal hematoma development, was assessed at 72 to 96 hours. And then follow-up again via clinic or telehealth visits was conducted by day 30 and 90. Diving into the baseline characteristics, we're looking at a median age here of 72 to 73 years, primarily female patient population in this study. And the median NIHSS score was 12. So a majority of patients did present fitting into more of that moderate stroke severity category. However, they did have a few patients in the study fitting in more of the moderate to severe category. The primary site of occlusion was the M1 segment of the MCA, so it's not surprising that majority of patients underwent thrombectomy. This was also followed by M2 segment occlusion and then occlusion of the ICA. What I wanted to highlight here on the third row was the last known well to time of randomization in both groups was about 12 hours. From the time the patient was randomized to actually receiving either tenecteplase or placebo, in minutes was about 13 to 14 minutes. So all patients from symptom onset to a needle time was about 13 hours. And then the time from IV thrombolytic administration to mechanical thrombectomy on average was about 15 to 17 minutes in either group, where if you'll see some patients got IV thrombolytics within 3 minutes just prior to thrombectomy. And then the primary reason for not undergoing mechanical thrombectomy in the study was if physicians decided those with M2 segment occlusion were not candidates. Looking at our primary outcome, there was no difference in functional outcomes at 90 days utilizing the MRS score. You can see at the graph at the bottom, there is a breakdown of the number of patients from each arm of the study and how many fit into each specific MRS score. Overall, pretty similar between the two groups with a median MRS score of 3. Key secondary outcomes and some safety parameters. So the investigators decided to look at functional independence at 90 days on top of some of the safety outcomes. And functional independence in this study was defined as having an MRS score of less than or equal to 2 at day 90. And you'll see that the incidence of this was very similar between the two groups, not surprising since our primary outcome also found no difference. Death within 30 and 90 days were similar between both arms, and then rates of symptomatic ICH and parenchymal hematoma development were also similar between those that received tenecteplase versus those that received placebo. For pertinent imaging outcomes, the recanalization at 24 hours, the incidence of that was documented by those that had an arterial occlusive lesion score of 3. This did trend higher to those in the tenecteplase group compared to those in the placebo group, but again, this did not correlate to any benefit in functional outcomes in this study. Reperfusion at 24 hours was the number of patients that had a 90% reduction in the penumbra volume at 24 hours, again, similar between tenecteplase and alteplase. And then Tiki score of 2B or 3B occurred similarly in both arms as well. And when taking a look at the predefined subgroup analysis for the trial, again, keep in mind this trial was not powered for conclusions from this analysis, but key takeaway here, there was really no difference or benefit from placebo versus tenecteplase in either of these subgroups. There did seem to be a trend toward favoring tenecteplase in those with M1 segment occlusion, but again, there was no difference and we cannot draw conclusions from this analysis. So based on the results of the study, the authors concluded that there's no benefit in functional outcomes with tenecteplase as compared to placebo when administered 4.5 to 24 hours after symptom onset in patients with acute ischemic stroke and large vessel occlusions with favorable imaging profiles. And again, the favorable imaging profiles are relating to having evidence of salvageable brain tissue. I think some benefits of this study, they had similar methodology to other landmark trials, especially other trials like the Extend IA T&K that looked at tenecteplase and thrombectomy. Because we're looking at patients with large vessel occlusions, we know that that is a standard of care for majority of those patients. So I do think it was a benefit for the high rates of thrombectomy, as this is what we would typically see in clinical practice. Some limitations or just things that I thought were interesting to note was the duration between thrombolytics and thrombectomy in the study. Here, on average, it was about 15 minutes to 17 minutes, depending on which group you're looking at. So it did seem like maybe some patients were getting IV thrombolytics directly in the angio suite, where I know at our hospital, patients would likely receive a thrombectomy and then have to be prepped for surgery, and it would certainly take a little bit longer than 15 minutes. So it would be interesting to see if that time frame could have possibly impacted any outcomes. I think one reason the time from thrombolytic to thrombectomy was so short in this study was the low representation of centers without endovascular treatment capability. So 97% of patients in this study were at a center with thrombectomy capabilities. So maybe giving us some insight that if patients already there and you can go to thrombectomy, that might be just the preferred option. And lastly, just something else interesting that I noted was NIHSS score indicating more of a moderate severity stroke score. I do think it was interesting that a lot of these patients presented around 12 hours. There wasn't a lot of diversity in terms of timing of initial presentation. I would have liked to have seen if maybe patients that presented within 4.5 to 6 hours or 4.5 to 9 hours may have had some type of benefit, but unclear to draw that from the study. So key take-home points, overall, there was no benefit in functional outcomes with tenecteplase compared to placebo, administered between 4.5 to 24 hours after symptom onset in patients with large vessel occlusion and favorable imaging. Could this possibly be beneficial for M1 segment occlusions? Potentially, but again, this would need to be validated with larger studies. There is also an unclear benefit in extending the window with IV tenecteplase in patients without large vessel occlusions, as those were the ones included in this study. But overall, this study, unlike what we saw with expanding the use of alteplase beyond 4.5 hours, showed no difference in incidence of intracranial hemorrhage. So likely potentially safe, but may just become a discussion of benefit versus risk. And just to keep everyone in the loop, hopefully we'll have some more clear answers come 2025. I did find 4 trials. There's probably a few more that I'm missing, but there are quite a few people looking into this expanded interval beyond 4.5 hours. There's some people looking at whether or not we should expand with or without thrombectomy. And then they're also comparing tenecteplase for alteplase in one study. So I'm interested to see some of the results and see how this could potentially impact our practice. That is all I have. So I would love to open the floor for any questions y'all may have for me or any discussion.
Thank you, Madeline, for that presentation. That was excellent. Does your center use alteplase or tenecteplase currently, and what are your prescribing patterns there in terms of, time windows?
Right. So we transitioned to tenecteplase at UT Southwestern in about April of 2021. So I feel like now we have a lot of comfort with tenecteplase use. But here, typically, if patients present outside of that 4.5 window, we do have thrombectomy capabilities here. So likely they'll go for mechanical thrombectomy. We'll also possibly screen the patient with a fast MRI to see if they're eligible for thrombolytics, if it's more of a wake-up stroke, but that's typically what I see done here at UT Southwestern.
Thank you. We've got a question in the chat here.
Yeah. Let's see. Sorry, let me pull up the chat here. Okay, so the question is, do you think we need more extended interval studies, or can we safely say at this point that 4.5 hours is a reasonable cutoff time for thrombolytic therapy? Personally, I think the key takeaway from this study is if the patient is at a center where we can go directly to thrombectomy, that's probably the preferred option. I think it might be interesting to have more extended window studies for more of a stricter time frame within that 4.5 hour to 6 hour window. Maybe even including some centers without thrombectomy capabilities if there might be patients with a longer delay between receiving thrombolytics and thrombectomy. And I say this because when I took a look back at the Extend IA T&K trial, looking at tenecteplase for LVO before thrombectomy, their average duration was closer to like 45 minutes between the two. But I think safely we can probably just stick to thrombectomy, but I would love to hear anyone else's thoughts on the subject.
I have a quick question. Thank you for that presentation, Madeline.
Thank you.
My name is Devin, by the way.
Hi, Devin.
I was curious your thoughts about, there were some signals of benefit, if there was a better recanalization rate in the tenecteplase group and the infarct volume had some difference. And then that M1 subgroup. Do you have any comment on if the study was adequately powered, or perhaps if they'd had more patients, if they would have seen what they were looking for?
Right. Unfortunately, the study was not adequately powered for the secondary outcomes or the subgroup analysis. So I do think it might be interesting to see if there was a benefit in those outcomes. In terms of the reperfusion outcomes and recanalization, again, unfortunately, we didn't see that correlate over to functional outcomes, but it might be interesting with a larger trial to see if that changed, or like you said, if there's benefit with that M1 segment occlusions. Does that answer your question?
Yes, thank you.
Yeah. And Karen said it seems like we still have good data for wake up strokes to go past 4.5 hour window. Definitely agree. Especially there was like the twist trial with tenecteplase and no increased risk of symptomatic intracerebral hemorrhage. So I do think it comes down to favorable imaging and then whether or not the patient's at increased risk for bleeding or has any contraindications.
Does anyone have other questions for Madeline?
So,
Okay, I don't see anything else in the chat, so excellent. Thank you, Madeline.
thank y'all for having me. Appreciate it.
Yeah. Okay, can everybody see my screen okay?
Yes, we can.
Okay, great. So my name is Danielle Murray. I'm a current PGY2 critical care pharmacy resident at Ohio Health Riverside Methodist Hospital in Columbus, Ohio. And today I'm going to be presenting on the Journal for Time to Anticoagulation Reversal and Outcomes After Intracerebral Hemorrhage, which was published in JAMA Neurology in February. Here is a list of abbreviations that I will be utilizing throughout the presentation. But to start us off with some background, so as we all know, ICH has a pretty high mortality, upwards of 30 to 40%. And hematoma expansion, which usually occurs in the first 2 to 3 hours of symptom onset, is an early independent predictor of mortality. And upwards of 20 to 40% of these patients can have hematoma expansion when they have initial scans within the first 3 hours of presentation.
Yeah, so
Hematoma expansion is usually our first priority and target when we have these patients come into our hospitals. And so therapies and practices.
And it has to be some space per.
Hematoma expansion have been increasingly studied. Around 18% of our intracerebral hemorrhages can occur in the setting of anticoagulation. So therefore, our patients are at more risk for hematoma expansion, rapid deterioration, as well as poor outcomes. So knowing that our patients on anticoagulation are at that increased risk, being able to identify these patients and treat them as soon as possible is really important. Currently, the 2022 ICH guidelines recommend that in patients with anticoagulation associated ICH, anticoagulation should be discontinued immediately and rapid reversal should be formed as soon as possible to improve survival. And this is a strong recommendation with limited data. So getting into the data that they do cite for this recommendation, starting off with our first study from Hanger and colleagues that was published in 2012. This was a retrospective single center study that included 88 patients with warfarin-related ICH. The authors found that earlier treatment with PCC was associated with a trend towards better survival when adjusting for ICH score. The next study that they cite in their recommendation was from Kuramatsu and colleagues. This was published in 2015 and was a retrospective multi-center study. They included 853 patients with oral anticoagulant associated ICH, specifically warfarin. And they found that reversal, as well as systolic blood pressure of less than 160 within 4 hours, was associated with lower rates of hematoma enlargement. So although the guidelines do recommend to reverse as soon as possible, as you can see, there is pretty limited evidence in this area on a specific time frame to reversal, which makes interpretation and implementation of that recommendation hard. And this doesn't just go for time to reversal. There is also a lack of specific goals and treatment recommendations in our ICH population as a whole. So recently there has been really this call to have more data in the ICH population to kind of have this ICH bundle and be able to treat our patients in kind of the same way that we treat our acute ischemic stroke patients. Earlier this year, there was this really great article published in Stroke, which was a call to action for a code ICH. And they really highlight the differences between the information and recommendations we have for acute ischemic stroke compared to ICH. They mention imaging, which in our acute ischemic stroke patients, we have pretty good criteria for who should get a CTA or a CT perfusion and how to interpret that data. Whereas in ICH, there is pretty inconsistent utilization of CTA, as well as how to interpret things like a spot sign. For blood pressure control in our acute ischemic stroke patients, we do have pretty defined systolic blood pressure goals, as well as recommended agents. However, in our ICH patients, we do have that range systolic blood pressure goal. But the only time metric that we have in the guidelines is to treat within the first 2 hours and achieve that goal within 1 hour. And this is only based on a pooled analysis of 2 trials. There's also limited data on how long to maintain this target, and there's no recommendation on what agents to use. Getting into our hematologic therapy for acute ischemic stroke, again, we have a pretty defined time frame from when we can administer thrombolytics. And we also have that goal of door to needle time of less than 60 minutes. However, like I mentioned, there's really no standards in our ICH in terms of hematologic therapy, specifically for reversal, with the guidelines only recommending as soon as possible. And lastly, criteria for surgical intervention. Again, there's really kind of no standards for role of craniotomy in our ICH patients versus our endovascular therapy for our acute ischemic stroke patients. With this, there has been an increased interest in looking at code ICH and ICH bundles. So I wanted to highlight some of these studies that have been published that did include rapid anticoagulant reversal in their ICH bundles. So first we have Perry Jones and colleagues who put out this study that was a single center retrospective study with 973 patients with ICH. In their bundle, they included rapid anticoagulant reversal within 90 minutes of arrival, as well as a systolic blood pressure target of 130 to 140 with a door to needle time of less than 60 minutes and neurosurgical referral. They found that implementation of the bundle was associated with a 10.8 percentage point reduction in 30-day all-cause fatality. The most recent one was from Ma and colleagues, and this otherwise known as the Interact-3 trial. This was a multi-center prospective study that included over 6,000 patients with ICH. In their bundle of care, they had a goal systolic of less than 140 with a body temperature less than 37.5 degrees Celsius, and then reversal for patients on warfarin for a goal INR of less than 1.5 within 1 hour of treatment. They also had defined glucose goals for those with and without diabetes, and these goals should be achieved as soon as possible. And they found improved functional outcomes in these patients who did receive this bundle of care. So although we have these studies that tell us that kind of having a goal-oriented approach to these patients can improve outcomes, it's hard to determine the extent of benefit in terms of the specific parts of the bundles. So taking a look at these specific treatments in this bundle can really help us kind of streamline our bundle. So the purpose of this study was to determine the association of door to treatment times for coagulopathy reversal and outcomes in patients who had anticoagulant associated ICH. This was a retrospective study that utilized data from the Get With The Guidelines Stroke Registry. This is a voluntary registry that hospitals can opt into. And this registry has been looked at in the past and has really helped guide our current acute ischemic stroke guidance for that door to needle time. They looked at patients that presented with an ICH from January of 2015 to December of 2021. They included patients who were direct arriving patients with ICH who were treated with reversal within 24 hours of symptom onset at participating Get With The Guidelines stroke hospitals, as well as those who were taking oral anticoagulants prior to admission, which they defined as in the week prior. They excluded patients who had an in-hospital ICH or if they were transferred from another hospital, if their primary diagnosis was subarachnoid hemorrhage, they were taking multiple oral anticoagulants, had a missing discharge destination, or if their INR was less than 1.4 in those that were taking warfarin. For their primary outcome, they looked at in-hospital mortality or discharge to hospice, and secondary outcomes that they looked at was discharge MRS, ambulation status at discharge, as well as discharge destination. For their statistical analysis, they assessed their baseline demographics using an absolute standardized difference, which they defined an absolute standardized difference of greater than 10% to be meaningful. They used a multivariable logistic regression model for the primary outcome. And in this model, they did adjust for factors that were expected to predict outcomes. And this included a lot of different factors. So demographics such as age, sex, race, and insurance status, past medical history such as AFib, PE, prior stroke, diabetes, as well as like obesity and antiplatelet use. They also adjusted for things like stroke severity, systolic blood pressure, And then like hospital differences such as the region, the teaching hospital, the number of beds, etc. So overall in this registry, they found over 17,000 patients who had an anticoagulant associated ICH. Of those, only 9,492 had a documented known reversal status. And of those patients, 7,469 patients received reversal. Of those, 5,224 received reversal with a documented workflow, and these were the patients that were used in the primary analysis. Of those patients, the median onset to treatment time was 232 minutes, with a median door to treatment time of 82 minutes overall. They put these patients into 4 different categories based on their door to treatment time. So 1,449 of them were treated within 0 to 60 minutes, 1,573 of them within 61 to 90 minutes, 1,029 of them within that 91 to 120 minutes, and then 1,173 were treated over 120 minutes from arrival. Getting into our patient characteristics. So we have our overall patient characteristics on the left, and then looking at the different door to treatment times. The p-value here can tell us basically if there's a difference between any one of the groups, but doesn't tell us where that difference lies. However, you can see a p-value that was less than 0.05 for race as well as atrial fibrillation. But overall, patients had a median age of 77. A little over half of them were male, and a majority of them were of white race. For medical history, around 70% in all groups had a past medical history of atrial fibrillation. A little less than 10% had a prosthetic heart valve. Around 33 to 34% across groups had prior stroke or TIA, and less than 10% in all groups had a past medical history of DVT or PE. Looking at the anticoagulant that these patients were on, around 60% in these groups were on warfarin, and around 20 to 25% were on apixaban, followed by rivaroxaban that around 15% of patients were taking. And then less than 2% of patients in all of these groups were also on dual antiplatelet therapy. Looking at our clinical data for our stroke severity score, overall it was 12, and you can see that as time increased from our door to treatment time, our stroke severity score decreased. Same thing with our systolic blood pressure. We had, as our door to treatment time increased, our systolic blood pressure decreased. And then for our onset to arrival time, again, you can see that as our door to treatment time increased, so did our onset to arrival time. For hospital characteristics, a majority of these patients did present to a teaching hospital. You can see there the annual ICH volume. So as patients had a longer door to treatment time, the less of the annual ICH volume that the hospital that they're admitted to saw. And then you can see the comprehensive stroke center, the percentage of patients that presented to a comprehensive stroke center. The authors did look at practice patterns that were associated with a door to treatment time of less than 60 minutes. So some factors that they found was white race, which I did want to highlight because our ICH guidelines do report that our Black patients are at a 1.6-fold higher increase for having an incidence of ICH. However, in this study, they were less likely to present earlier after symptom onset, and they were also less likely to get quicker treatment once they did arrive, which I think really highlights the disparity in the care that these patients are receiving, and definitely something to try and target in our patients. Other factors that were associated with a door to treatment time of less than 60 minutes were a higher systolic blood pressure. They do note that lower stroke severity was associated with a door to treatment time of less than 60 minutes with an odds ratio that they reported of 1.25. However, like I mentioned in the baseline characteristics, it did kind of seem opposite. However, in their statistical analysis, they noted that lower stroke severity was associated with a door to treatment time of less than 60 minutes. And then hospitals with a higher annual ICH reversal, with these patients were also associated with a door to treatment time of less than 60 minutes. Something else that I did want to highlight was what reversal agent these patients got. As you can see, not a lot of patients had that information documented, but since it is kind of a widely debated topic, I did just want to present that information. So most notably in patients who are on a DOAC, 66.7% of patients received PCC and 26.2% of patients received andexanet alpha. Again, you can see that there was not that many patients who had this information available, but I just thought it was interesting to note the different practice patterns. So for our primary outcome of in-hospital mortality or hospice discharge, 46.1% of patients in our early group versus 41.2% of patients in our later group had that primary outcome. And the adjusted odds ratio, they did find statistical significance with an odds ratio of 0.82, so that our patients who were treated earlier, so a door to treatment time of less than or equal to 60 minutes, were less likely to have in-hospital mortality or hospice discharge. They looked specifically at in-hospital mortality, and you can see that the adjusted odds ratio did have a confidence interval that included 1. For our secondary outcomes for our MRS score of 0 to 2 versus 3 to 6, there was no statistical significance in the adjusted model. For ambulatory or with or without assistance, again, there was no significance in the adjusted model. And then for discharge home or to inpatient rehabilitation, there was significance in the adjusted model with an odds ratio of 1.23. So based on this study, what the authors concluded was that earlier administration of reversal interventions and anticoagulant associated ICH was associated with reduced in-hospital mortality or discharge to hospice, but there were no difference in functional outcomes. So getting into the strengths and limitations. So strengths of this study include the large sample size and the heterogeneous patient population that they included. I think that this better represents real-world patients and practices and is more generalizable to all patients and institutions. A lot of our other reversal studies might have a little bit more strict inclusion and exclusion criteria. They might exclude our more severe ICH patients. So I think that this study just better represents kind of the real world and our patients. However, some limitations for this study, obviously the retrospective nature, the data is going to be limited by the quality of documentation. There could potentially be a selection bias in this trial as well. So like I mentioned, kind of in that flow of what patients were included, only 54% of patients in that registry had a documented reversal status. So there was a good percentage of patients who did present with an anticoagulant ICH that just weren't included in this study that were in the registry. And then another limitation that I wanted to note was our door to treatment time being analyzed as a categorical value. So either less than or equal to 60 minutes or greater than 60 minutes. I think that this limits us being able to see if there's an additional benefit if patients were reversed in that less than 60 minutes, or if there was a certain time frame greater than 60 minutes where outcomes became a lot worse. So some key takeaway points from this study. I do think that this study supports early reversal and that it can result in improved outcomes. There was no difference in our MRS score, which is our gold standard for our neurocritical care patients. However, there may have been differences that we just weren't able to see in the study due to different confounding factors, even though the authors did try to adjust for this. They did find a difference, though, in patients who were discharged home or to rehab, which can look at independence, and that was significant in this study. I think based on the study, a door to treatment time of less than 60 minutes can be implemented into hospital workflow as a part of an ICH bundle. So like I mentioned, it's definitely gaining increased popularity and trying to kind of have a bundle of care for these patients. So I think that this study can really be used to kind of have that 60-minute cutoff mark and to have that goal-directed therapy for these patients. I think further research needs to be done to see the impact of even earlier door to treatment times. So if there's any more benefit in reversing patients maybe within the first 45 minutes or 30 minutes, but that study just wasn't able to show us that. Lastly, I also just wanted to highlight that this study can also be used to really highlight pharmacist presence at the bedside. Recently, there was an article published in the Journal of Emergency Medicine, and they looked at emergency medicine pharmacists at bedside who were present for patients who presented with an ICH. And what they found at their center was that having a pharmacist at bedside decreased time to reversal by 36 minutes. So when you take that study and you also take this study and wanting to reverse our patients as soon as possible, I think we can really utilize this to kind of highlight having pharmacists implemented into these ICH bundles and being at the bedside for these patients. All right, so with that, I'll take any questions that anybody has, and then I would also be interested to hear anybody's opinions on if your institution is working on implementing some sort of ICH bundle, or if this study is going to change anybody's practice.
Thank you, Danielle, for that excellent presentation. We do have one question in the chat already. Basically, I think the question that's on everybody's mind is which agent, to use for reversal. And so this particular person is asking about Indexa and idarucizumab, which, for their respective DOACs in theory are preferred, but obviously not all institutions carry Indexanet on their formulary. So we're all waiting on the results of this trial to come out, but I guess we're curious to hear your thoughts on reversal agents.
I guess I don't know if I want to open that can of worms, but obviously in this study, like a lot of patients did not have that documentation, so they couldn't really like adjust for that. I guess I'll go out and say that I'm more of a PCC person, but again, like everybody else, I am definitely waiting for the results of that new trial. I also think with this study, kind of supporting a quicker door to treatment time, I do think that PCC has that advantage of kind of being able to quickly get to bedside and compound and dose it. So I think that this study can be used to kind of maybe support that. And then another person asked about,
do you see Devin's question?
Yeah, I did. So they did not comment on parameters for DOAC patients, which again, with it being retrospective, I think that there were probably some of these patients who maybe they didn't know if they were still taking their DOAC, and some patients might have been reversed who didn't need reversal, but there also might have been patients who didn't get reversed who needed reversal. I think that's another kind of something that still needs to be studied, is how can we detect if a patient is taking their DOAC. I mean, I think thromboelastography is kind of becoming the new big thing, but I still think that's like a really big question for these patients when they come in.
Danielle,
Danielle,
this is Casey. I have a quick question for
Go
you.
ahead.
I'm just curious if I might have a delay. I'm not sure, but I'm just curious if you have thought, outside of having a pharmacist at the bedside, what are other things that we can do as a pharmacy community to help bring down that door to needle time for anticoagulation reversal, because it's going to happen soon. So what thoughts do you have with that?
I definitely am a really big fan of the bundles. At the institution that I'm at, we do have kind of like a hemorrhagic stroke alert that is called overhead, just like a normal stroke alert. And we do have pharmacists that go to all of these. So they're present there for patients if reversal is needed. And we do actually in our protocol have a goal to reverse patients within 60 minutes. And I think when you just have a pharmacist that is expected to be going to these hemorrhagic stroke alerts, and then kind of also having that goal. I think it kind of, everybody's kind of on the same page. And I think just kind of having more of a protocolized approach, I think can help get patients reversal quicker.
Yeah, thank you. And the other piece I think that we help with is protocol development and order sets, which make things more accurate and quicker to order if we're not there, because not everyone has 24-hour pharmacy coverage in the ED. So that's really helpful for them. Thanks.
Mm-hmm.
There's another question about whether the authors commented on number of patients that required neurosurgical intervention in the different arms, and if that's something that you saw when reading this trial.
Yeah, so the authors did not comment on that. Again, I would assume that it just wasn't something that was documented through this registry, but it wasn't commented either, both in the article as well as in the supplemental.
Yeah, I didn't see that. I was also looking about the use of antiplatelets in these patients. It looks like it was pretty similar between the groups, but I didn't see any mention. It looks like up to 30 something % of patients were on desmopressin or anything like that. Did you see anything?
I don't know. And you kind of cut out. I think you were talking about antiplatelets, but I didn't see like any like huge differences in terms of antiplatelet use. No.
Okay, any other questions for Danielle? Well, great job. Thank you for presenting both great presentations today.